What if the most crucial journey a life takes happens long before, well, before a single step is ever even imagined?
It's quite a thought, isn't it?
It is. Today we're taking a deep dive into the fascinating, complex, and often pretty silent world of equine fetal health. Specifically, uh, understanding stress, distress, and viability in the developing foal.
A really vital topic.
Absolutely.
Yeah.
And, you've given us this incredible stack of in-depth sources like specialist standard study guides. So
Mm.
our mission today is really to pull out the most important nuggets of knowledge from all this material.
Kind of give you a shortcut.
Exactly, a shortcut to being well-informed.
Hmm.
We want to help you navigate this critical area of equine reproduction, understand the signs, both subtle and, well, not so subtle signs of trouble,
Yeah.
and learn about the crucial interventions that can genuinely make all the difference. So get ready for, I think, some surprising facts and some really essential insights.
It's definitely got real-world importance for anyone involved with horses.
Okay, so let's start unpacking this. When we talk about fetal health in horses, these terms stress, distress, and viability, they come up constantly. What exactly do we mean by each of them in this context?
Yeah, defining them clearly is really important. So, fetal stress. Think of it as a physiological response. The fetus is reacting to a perceived threat or challenge while it's still in the uterus.
Like an internal alarm bell.
Exactly. It often involves the activation of what's called the hypothalamic pituitary adrenal axis, the HPA axis. It's the foal's internal warning system kicking in. Now, this stress, it can sometimes lead to adaptive changes, like, say, accelerated maturation of certain organs, which might sound good,
Right. Sounds potentially helpful.
but, and this is the key part, if that stress is prolonged or if it's really severe, it can quickly tip over into actual distress.
Ah, okay, so distress is the next level up.
Much more severe, yes. Fetal distress indicates that the foal's well-being is genuinely compromised. Usually it's because of inadequate oxygenation, we call that hypoxia, or maybe insufficient nutrient supply.
So the lifeline is failing somehow.
Pretty much. It really means the fetus is struggling.
Mm.
Struggling to maintain its basic functions, and it's at serious risk of irreversible damage or, even death.
And viability, where does that fit in?
Viability is simpler, really. It just means the capability of the fetus to survive and develop normally outside the uterus.
Okay.
And that's heavily, heavily dependent on gestational age, obviously, and any underlying conditions the foal might have.
So just to simplify,
Yeah.
stress is the warning signal. Distress is when it's become an actual emergency,
That's a good way to put it, yes.
which really highlights how critical early detection must be.
Absolutely critical. Equine pregnancies are generally pretty robust, but complications can definitely arise, and often very silently.
Sneaky.
Yeah. So early detection of stress or distress is crucial for intervention. It can potentially prevent stillbirth or neonatal maladjustment syndrome, NMS, or just, the birth of a foal that's already compromised. Optimizing that peripartum management, the care around birth, based on the fetal status, it can significantly improve a foal's survival chances and its long-term health.
So what's unique about equine fetal development then? What makes this deep dive so specific to horses? It sounds like there are particular challenges.
There are definitely a few things that really set it apart. Firstly, horses have what's called an epitheliochorial placenta.
Okay, that sounds complicated.
It just means there are several tissue layers between the mare's blood and the foal's blood. And the key thing is this prevents those critical maternal antibodies from crossing over in utero.
Ah, unlike in humans.
Exactly. So foals are born completely naive, immunologically speaking. They are entirely dependent on getting that passive immunity from the mare's colostrum after birth, that first milk.
Which makes that first drink incredibly important.
Hugely important. It's a significant vulnerability. Secondly, that peripartum period, the transition from inside the uterus to outside, it's incredibly precarious for foals. Healthy ones transition fast, but compromised foals, they often struggle immensely. And lastly, and this is really important, the fetus undergoes significant rapid growth and organ maturation, especially the lungs, in the last, say, 60 to 90 days of gestation.
The final stretch.
Exactly. That final window is a critical period for ensuring fetal well-being because so much vital development is happening right then.
Makes sense that so much is packed into those final weeks.
Yeah.
So, given these unique aspects, what actually causes a foal to experience stress or distress in the first place? You said it can be varied.
It truly can be. Fetal stress and distress, they typically stem from issues affecting one of three main areas: the mare herself, the placenta, or the fetus.
Okay.
And in almost all cases, these issues ultimately lead to compromised nutrient delivery or oxygen delivery to the developing foal. That's the common pathway.
Let's start with the mare then. What kind of conditions can she experience that might directly impact the foal?
Maternal systemic illnesses are a really significant category. We're talking about things like severe colic, especially surgical colic,
Right, major stress.
major stress, pain, endotoxemia, altered blood flow, all bad for the pregnancy. Severe laminitis, too, that causes systemic inflammation and stress.
Mm-hmm.
Any severe infectious disease in the mare, like pleural pneumonia or Potomac horse fever, things that cause fever, endotoxemia, they can directly impact fetal health.
So it's not just about reproductive health.
Not at all. And beyond illness, think about severe physical or psychological stress on the mare, like prolonged transport, major instability in the herd, that can negatively affect the pregnancy too.
Wow.
Other maternal conditions, things like nutritional deficiencies, endocrine imbalances, PPID,
Right.
what used to be called Cushing's or MSR, direct abdominal trauma to the mare.
Ouch.
Yeah. And then there are more specific conditions the sources mention, like enterocolitis, hyperlipemia, a prepubic tendon rupture, uterine torsion, even things like a granulosa cell tumor.
What a list.
It is. And then you have environmental factors or exposures. Exposure to ergopeptine alkaloids.
That's the fescue thing, right?
Exactly. Endophyte-infected fescue grass, or ergotized grasses and grains. That's a big one. And of course, abortogenic infections, equine herpesvirus is a major one, or bacterial contaminants, like the ones associated with eastern tent caterpillar setae.
So it seems like almost anything that severely impacts the mare's overall health can indirectly put the foal at risk, even if it's not directly a reproductive issue itself. Is that fair?
That's absolutely the key takeaway there. The mare's whole system health is just intricately linked to the fetal environment. Now, while the mare's health is obviously critical, the sources really highlight the placenta as a major, major player.
Often the primary culprit.
Often where things go most critically wrong, yes.
So if the placenta is the lifeline, what commonly goes wrong there?
It is the absolute lifeline, and when things go wrong with it, it's immediately serious for the foal. One of the most common issues and a huge cause of fetal distress is placentitis.
Inflammation of the placenta.
Exactly. Inflammation, thickening, sometimes separation of the choriolantua. That's the outermost fetal membrane, the part that attaches to the uterine wall and does the nutrient and oxygen exchange.
Okay.
So when it detaches or gets inflamed, that vital exchange is immediately compromised. There are different types. Ascending placentitis is the most common, usually bacterial or fungal infections creeping up from the cervix.
Makes sense.
Then there's nocardioform placentitis, often more diffuse and severe, and systemic placentitis, which is from infection spreading through the bloodstream.
What would an owner see?
The key signs of placentitis owners should watch for are premature udder development or lactation, often called running milk, or maybe a vulvar discharge. And on ultrasound, we can see that thickening, particularly near the cervix.
Right. What else can go wrong with the placenta besides infection?
Well, beyond infection, you can have placental insufficiency. Fescue toxicosis is a prime example we already mentioned. Those ergot alkaloids cause vasoconstriction.
Squeezing the blood vessels.
Right. Compromising placental blood flow and development. That often leads to prolonged gestation, abnormally large foals, and agalaxia, the mare not producing milk.
Okay.
Then there's hydrops, allantois, or amni, that's excessive fetal fluids, which physically stresses the placenta and the uterus. Twin pregnancies, a major cause.
Because they have to share.
Exactly. Placental sharing often leads to small, compromised foals or even abortion, especially common in breeds like thoroughbreds, standardbreds, drafts, and miniature horses.
Interesting breed predisposition.
Yeah. We also see placental dysmaturity, or just aging, sort of, which is more common in older mares or maybe very prolonged gestations. And kind of a newer area, placental abnormalities have been reported with foals that result from cloning procedures, SCNT.
Fascinating. Now, that red bag delivery, you mentioned that's an emergency. Can you describe that again?
Yes, absolutely, an extreme fetal emergency. If you see a red, velvety-looking bag protruding from the vulva during foaling.
Instead of the normal whitish membrane?
Precisely. That red bag is the choriolantua itself. It means it is separated prematurely and completely from the uterine wall. The foal's oxygen supply is immediately completely cut off.
Zero time to waste.
Zero time. You have to rupture that red membrane immediately and get the foal out fast with strong traction. It's life or death in seconds.
Understood. Any other placental or cord issues?
Umbilical cord abnormalities are another concern. If the cord is excessively long or gets twisted,
Like a knot.
yeah, it can kink, get compressed, or block the blood vessels, causing fetal hypoxia. We can also see hematomas, edema, strictures in the cord, or even torsion of the amnion, the inner sac.
Okay, so we've covered the mare, the placenta. What if the problem starts with the foal itself? Are there issues internal to the foal?
Yes, absolutely. Sometimes the issue is primarily fetal. This could be things like in utero infections, viral, bacterial, protozoal, or fetal malformations, congenital anomalies that just impede normal development.
Birth defects, basically.
Right. Foals can also be oversized, like you mentioned with fescue sometimes, or undersized due to severe placental insufficiency or some other fetal disease, sometimes called intrauterine growth retardation.
Ew, UGR.
Exactly. Fetal trauma is possible. And again, those foals resulting from SC&T cloning procedures seem to have some unique potential issues.
Okay.
And while it's not technically fetal distress in utero, we absolutely have to consider the risk of neonatal isoerythrolysis, or NI, before foaling.
That's the antibody issue with the colostrum.
Yes, where the mare's colostrum has antibodies against the foal's red blood cells. It doesn't cause distress before birth, but poses a huge risk right after birth, so it's part of the pre-foaling risk assessment.
Got it. So it sounds like all these different factors, mare, placenta, foal, they can all kind of push the foal down this path from initial stress into severe distress.
That's precisely the progression. The pathophysiology is basically if that initial problem, that stressor, isn't fixed quickly, the fetus tries to cope physiologically. But these coping mechanisms can become maladaptive.
Like what?
Like the foal might pass meconium, the first stool, and inhale it. Or its respiratory movements might decrease. Or the heartbeat becomes irregular, all signs leading towards compromise and potentially death.
Right.
Even acute fetal stress, a sudden severe event, can sometimes trigger premature birth of a foal that's just not viable. So yeah, that progression from stress to distress, it very often results in either fetal death or a severely compromised newborn foal.
Okay, this really brings us to the detective work.
Mhm.
How do vets figure out if a foal is in trouble while it's still inside? I mean, it seems incredibly challenging.
It definitely requires careful work, yeah. But antenatal monitoring, especially in pregnancies we know are high risk, is absolutely crucial. We have tools.
So what are the big red flags we should be looking for? Or maybe which mares are considered high risk and need that closer watch?
Okay, high-risk mares. Think about history. A mare with a history of previous abortion, stillbirth, maybe delivering an NMS foal, or having had placentitis before.
Makes sense.
Also, known fescue exposure, advanced age, especially over 15 years old. Mares in poor body condition, carrying twins, or maybe having had a difficult birth, dystocia, previously.
Pre-existing conditions, too.
Yes, definitely. Mares with things like PPID, MSRR, or known chronic endometrial inflammation, maybe fibrosis or lymphatic cysts in the uterus, all raise the risk level.
And what signs might the mare herself show?
Clinically, the number one sign, the most crucial early warning, is premature udder development or lactation, that running milk, especially if it happens before day 320 of gestation.
Okay.
That is highly suggestive of placentitis or maybe impending abortion, though remember, it's often absent in fescue toxicosis cases.
Right, because they have trouble producing milk.
Exactly.
Yep.
Other signs, vulvar discharge could be bloody, purulent, bad smelling. The mare might show signs of colic, discomfort, maybe intermittently, maybe severely, or just signs of systemic illness, like a fever.
And the opposite of running milk.
Right. A lack of udder development combined with a prolonged gestation that points towards fescue toxicosis. You might also notice excessive swelling along her belly midline, maybe signs the body wall is weakening, or just a really excessively large abdomen.
Okay, now I know ultrasound is key here. Can you walk us through what veterinarians are actually seeing on the screen? What are they measuring?
Ultrasound is absolutely the cornerstone. With transrectal ultrasound late in gestation, one of the primary things we measure is the CTUP combined thickness of the uterus and placenta.
Right, you mentioned that earlier.
Yeah, it's measured down near the cervix. And basically, if that measurement gets thicker than it should be for that stage of pregnancy, say over 8 millimeters between 270 and 300 days, or over 10 millimeters after day 300. That's a big red flag for placentitis.
Indicating inflammation and swelling.
Exactly. They'll also look at the placenta itself for signs of separation, edema, maybe changes in echogenicity, and check the cervix too.
And then transabdominal, looking through the belly wall.
Yes. Transabdominal ultrasound gives us a look at the fetus itself. And here, the fetal heart rate, the FHR, is probably the single most reliable indicator of acute fetal stress or distress.
What are the numbers?
Normal is roughly 70 to 110 beats per minute, but it varies with activity, just like us.
Yeah.
A heart rate that's consistently too fast, say, persistently above 110, 120 BPM, that's an early warning sign of stress, maybe hypoxia. But a heart rate that's consistently too slow, persistently below 60 BPM, that's a grave sign.
Really bad news.
Really bad. Indicates severe distress, maybe impending demise, or even fetal death. Now, there's nuance. A temporary high heart rate after the foal moves might just reflect stress, not immediate distress, but a very low resting heart rate, especially below 50 after day 330. That suggests central nervous system depression, likely from hypoxia, and it carries a poor prognosis if it persists.
And no heartbeat means?
Absence of a heartbeat confirms fetal death, unfortunately. Arrhythmias also suggest compromise.
What else can you see on the abdominal ultrasound besides heart rate?
Lots. We assess fetal activity. Gross body movement should be happening. If they're absent, that indicates severe distress. Fetal breathing movements, these are little diaphragm movements, we look for episodes. Their absence can indicate hypoxia.
Like practice breathing?
Kind of, yeah. Fetal tone, limb flexion, and extension. Loss of tone suggests severe distress. We can measure things like the aorta diameter to estimate fetal growth and perfusion, and we look at the fetal fluids.
Too much, too little?
Exactly. Assessing volume for hydrops, too much, or oligohydramnios, too little. And we look at the fluid's echogenicity. Is it clear or is there debris floating around? Debris can indicate inflammation or stress. We have normal ranges for fluid depth to compare against.
Well, a lot of information there.
And finally, we assess overall fetal growth using biometrics, and we can sometimes spot major congenital anomalies.
So it's not just a static picture. It's about how the foal is behaving inside, too. Beyond the imaging, can blood tests help? Hormones?
Yes, absolutely. Hormonal changes in the mare's blood give us vital clues. Estronate sulfate, or E1S, is a big one. It's produced by the fetal placental unit.
So it reflects both?
Yes, exactly. It's considered an excellent indicator of fetal viability and placental function. If those E1S levels are consistently low, or if they're decreasing late in gestation, that indicates compromise. Normal levels are very reassuring for a live fetus.
Okay, what else?
Progestogens, or total progestins. They're also used to assess placental function. Interestingly, levels might be elevated if there's infection, possibly indicating fetal stress, while low levels suggest placental insufficiency or impending loss. And maternal prolactin levels, if they're low late in gestation, that strongly suggests fescue toxicosis. There are also some anecdotal reports about decreased maternal relaxin or lower thyroid hormone levels, but their significance isn't really well understood yet.
Are there any other diagnostic tools, maybe more invasive ones?
There are. Transabdominal amniocentesis, or allantocentesis, that's taking a sample of the fetal fluids with a needle through the mare's abdomen.
That sounds risky.
It is higher risk, yeah.
Yeah.
Generally reserved for specific cases, maybe where infection is highly suspected. The fluid can be checked for bacteria, meconium, inflammatory cells. You can also potentially assess fetal lung maturity or look at chromosomes.
Okay.
And then, of course, if the worst happens and there's an abortion or stillbirth, a necropsy and autopsy of the fetus and placenta is absolutely crucial for getting a definitive diagnosis of what went wrong. Pathologists can find specific signs like villus atrophy on the placenta or thickening and edema. And sometimes an endometrial biopsy from the mare later can show underlying chronic issues.
Okay, so once you have a diagnosis, maybe placentitis or fetal distress is confirmed, what can actually be done? It sounds like time is incredibly critical.
Time is definitely of the essence, and the treatment really depends heavily on what the specific cause is and how far along the pregnancy is. The main goal is always to try and stabilize the mare, resolve the underlying problem if possible, and support the foal's well-being to allow the pregnancy to continue safely to term.
Ideally, keep the foal inside longer.
Ideally, yes. Early diagnosis is key, as we've said. And honestly, managing these cases is often best done at a specialized clinic or hospital that's equipped for high-risk pregnancies, especially if the foal is showing signs of significant distress.
Right, so for placentitis, what's the typical approach?
For placentitis, systemic antimicrobials are really the cornerstone. Broad-spectrum antibiotics drugs like trimethoprim sulfamethoxazole, or maybe penicillin combined with gentamicin or ceftiofur. And often, this is long-term therapy, like weeks or even months.
Wow.
Anti-inflammatories are also critical. NSAIDs like flunixin and meglumine or maybe firocoxib to reduce that inflammation, both systemically and in the placenta. Sometimes pentoxifylline is used too. It might help improve microcirculation and has some anti-inflammatory effects.
What about hormone support, progesterone?
Progestin supplementation. It's actually quite controversial now. It was historically used a lot kind of to support the pregnancy, but there's limited evidence it directly counteracts the problems in placentitis. It might still be used if the mare's natural levels are documented to be low or just as general supportive care, but it's not a magic bullet.
Okay.
And if premature birth seems likely, say within the next 72 hours, dexamethasone, a steroid, might be given to the mare to try and quickly mature the foal's lungs. But that comes with a big caution sign.
Why is that?
Because dexamethasone can potentially induce abortion or premature labor itself, and it carries a risk of causing laminitis in the mare. So, risky.
Definitely trade-off. Now, fescue toxicosis, you mentioned that's common. What's the specific fix for that?
It is common in certain areas. For fescue toxicosis, the absolute crucial first step is get the mare off the fescue pasture.
How long before foaling?
Ideally, 60 to 90 days before her due date. Minimum, absolutely minimum, is 30 days prepartum. And then there's a specific medication, domperidone. It's a dopamine antagonist. You give it daily, starting maybe 10, 15 days before the expected foaling date, or as soon as you suspect fescue toxicosis. It works by promoting prolactin release, which helps with mammary development and allows normal parturition to occur. You usually continue it for about 5 days after foaling, too.
Got it. Now back to that red bag scenario.
Yeah.
The immediate emergency. What is the action again? Just to be crystal clear.
Crystal clear. Extreme emergency, immediate intervention required. See the red velvety bag, rupture it immediately. Don't wait. Then deliver the foal as quickly as possible using strong, steady traction. Its oxygen is gone, so every second counts.
Okay. What if there's acute fetal distress, but it's not from infection or placentitis? Say, the mare is sick for another reason.
Right. In those non-infectious cases, the focus shifts mainly to supporting the mare. Treat her underlying illness, colic, dehydration, shock, whatever it is. Sometimes maternal oxygen supplementation might help, along with IV fluids to optimize her hydration and blood flow, which indirectly helps the foal.
Makes sense? Support the mom to support the baby.
Exactly. Now, as a very last resort, if the fetal distress is severe, the foal is near term, and it seems viable, induction of parturition or even a C-section might be considered to try and save the foal.
But you mentioned induction is risky.
Highly risky, yes. And it's really strongly discouraged if the fetus isn't clearly mature and viable. Inducing a premature foal often just leads to delivering a severely compromised foal that struggles to survive, so it's a very careful calculation.
So inducing labor isn't just a quick fix. How do specialists decide if a foal is actually ready for induction? What are they looking for?
That's a critical assessment. Induction should only be considered when specific criteria for fetal maturity and viability are met. We don't want to jump the gun.
What are the criteria?
First, gestational age. Should be at least 330, 340 days, maybe more, depending on the breed. Second, the mare needs to show significant udder development, what we call waxing those little beads of colostrum on the teats. Third, the colostrum quality itself needs to be good. We can measure it. Using a refractometer for Brix percentage, looking for 23% or higher or specific gravity, aiming for 1.060 or more.
Oh.
Then, there are electrolyte changes in the mare's milk secretions. We do serial measurements. Calcium is a key one, needs to rise above a certain level, say 100, 200 parts per million, and stay there for 24, 48 hours. Ionized calcium is even more accurate. We also look for potassium to go up and sodium to go down.
So chemistry changes in the milk signal readiness.
Exactly. And finally, the fetal ultrasound findings are crucial. Heart rate, activity, breathing movements all need to look normal. No signs of severe distress. Only if all these boxes are ticked would induction even be considered.
And if they decide to induce, how's done?
If indicated, the protocol usually involves oxytocin. Given in low doses, often as repeated IV infusions, maybe 5, 10 international units every 15, 30 minutes until strong contractions start.
But still risky, you said.
Still risky. Induction increases the risk of dystocia, difficult birth, premature placental separation, that red bag again, retained fetal membranes for the mare, and delivering a compromised full NMS, failure of passive transfer. You absolutely have to weigh the risks versus the potential benefits very carefully.
Right. Are there other management things, like activity levels for the mare?
Yes, good point. Depending on the condition, activity restrictions might be necessary. Exercise might be limited and supervised, or in some cases, like with a prepubic tendon rupture, severe laminitis, or fetal hydrops, stall rest might be strictly enforced.
Okay. So even with all these diagnostics and interventions, what's the general outlook? What's the prognosis for foals that have gone through stress or distress in utero?
It's highly variable, unfortunately. If the cause was relatively minor and it got resolved quickly, the outlook can actually be excellent. They can bounce back.
Good to hear.
But for foals that experienced prolonged or severe hypoxia, the prognosis becomes guarded. There's a higher risk of issues like NMS, other neurological problems, or organ damage.
And if the underlying problem is really bad?
If there's severe irreparable placental damage or significant umbilical cord abnormalities or severe fetal malformations, then the prognosis is generally poor.
So if a compromised foal is born, what happens then? What's the immediate care?
Aggressive neonatal intensive care is absolutely critical. Right at birth, immediate needs might include resuscitation oxygen, respiratory support if they're not breathing well.
Okay.
You basically have to assume they have failure of passive transfer, FPT, so test their IgG levels as soon as possible and provide good quality oral colostrum or maybe an IV plasma transfusion to get those vital antibodies in.
Immune support is key.
Absolutely. And infection control. Start broad-spectrum antibiotics right away, empirically, then adjust based on culture results if needed. Basic needs are huge, too. Nutritional support, maybe via a nasogastric tube if they can't nurse, or IV fluids, thermoregulation keeping them warm, managing fluids and electrolytes carefully.
And specific issues like NMS.
Yes, specific support might be needed. For NMS foals, neurological support, things like the Madigan squeeze technique, maybe anticonvulsants, other brain protectants, plus organ-specific support if there's evidence of kidney, liver, lung, or GI compromise.
Sounds intensive.
It is. And identifying the underlying cause is still important, examining the placenta thoroughly, maybe genetic testing on the foal, infectious disease workups. Finally, long-term monitoring is often a good idea because some foals that experience stress in utero might have subtle long-term neurological or developmental issues.
So those first few hours and days are really make or break, aren't they? Constant vigilance needed.
Absolutely. Make or break is a good way to put it.
And it's clear that even with the best treatment, significant complications can still happen for both the mare and the foal.
Yes, unfortunately, that's true. For the mare, potential complications include abortion, obviously, dystocia, retained fetal membranes, which can lead to metritis and laminitis, septicemia, trauma to the reproductive tract, and potentially impaired future fertility.
And for the foal, beyond the immediate survival.
Neonatal foals that were compromised during pregnancy are just generally more likely to be dismature, meaning underdeveloped for their gestational age. They're more prone to septicemia and more likely to have issues like angular limb deformities compared to foals from normal, uncomplicated pregnancies.
Given all this complexity, all these potential problems, what's the big picture message for prevention? How can owners try to avoid these situations?
Prevention really starts with recognizing those at-risk mares we talked about earlier, and then being proactive. If a mare has poor perineal conformation, correcting that surgically can help prevent ascending placentitis. Managing any pre-existing endometritis before breeding is crucial.
Good preparation.
Exactly. For mares with a known history of problems, early and continuous monitoring throughout the pregnancy is vital. Keeping complete and accurate breeding records is surprisingly important, too. Knowing ovulation dates helps diagnose twins early for potential reduction, for example. Careful monitoring of all pregnant mares for those subtle signs, like vaginal discharge or premature milk letdown. We talked about fescue removing mares from fescue pasture or ergotized grains during that last trimester, ideally 60 days, minimum 30 days prepartum. That's huge.
Simple but effective.
Yeah. Sometimes using embryo transfer can be a good strategy for mares known to have issues maintaining a pregnancy, or those considered high risk. Conversely, it's also important to think about not breeding or not using ET from mares that have repeatedly produced stressed, distressed, or dead foals due to conditions that might be congenital or heritable.
A tough decision, but maybe necessary.
Sometimes, and just general good practice, prudent use of any medications in pregnant mares, and avoiding exposure to known toxins.
And owner awareness, I guess.
Client education is critical. Owners need to understand the risk factors, why early diagnosis is so important, the potential need to correct or manage predisposing conditions, and frankly, the significant financial and emotional commitment that might be required for intensive neonatal care if things do go wrong.
That's a really important practical point. This deep dive, it's really painted such a vivid picture of both the incredible fragility, but also the resilience of equine fetal life. For our listener, What do you think is the biggest takeaway message from all this detail?
Well, I think the good news is that our ability to prevent, diagnose, and treat many of these conditions leading to fetal stress and distress has improved significantly over the years. We have better tools, better understanding.
That's positive.
It is. But successful management of these at-risk pregnancies still requires rigorous, continuous monitoring of the mare, of the fetus, and then of the neonate after birth. It's intensive. If those predisposing conditions can be treated or managed effectively, pregnancies diagnosed as stress, well, they have a guarded but potentially okay prognosis for reaching term.
But if it progresses,
But if the evidence of stress progresses to actual distress, and that distress continues despite treatment efforts, then the prognosis for a successful term gestation definitely becomes guarded to poor. Early intervention is key, but sometimes the damage is too significant.
what a journey into this hidden world of equine fetal health. It really is a powerful reminder that even before birth, there's just this whole world of challenges and also incredibly dedicated care happening.
Indeed, understanding these really intricate systems and recognizing the signs of trouble, even the subtle ones, it truly can make the difference between, a tragic loss and a thriving, healthy foal. It just underscores how critical every single stage of pregnancy is.
So reflecting on this whole discussion, what particularly stands out to you? Maybe the sheer number of things that can go wrong or perhaps the amazing diagnostic tools vets now have.
What really strikes me, thinking about all these factors, is how profoundly maternal health and the environment impact fetal development. It raises a bigger question, I think.
Which is,
Considering that profound impact, what responsibilities do we as caretakers really have in optimizing the preconception environment and the early gestation environment, trying to create the healthiest possible start long before any signs of stress might even appear?
Hmm. That's a great thought to leave people with, encouraging us to think even more holistically right from the very beginning. Well, we hope this deep dive has given you a valuable shortcut to being well informed on this really critical topic. Thank you so much for joining us.